Thank you all for joining us for the National Spine and Pain Center's webinar series. We will now begin the program with our moderator, Dr. Peter Statz. Peter, take it away.
Oh, thank you. Welcome everybody to the first ever combined National Spine and Pain Center Clinical Development Series program. That's really kind of a cool program that we're getting started today for the combined NSPC Prospera family. It's a bit ironic in some ways that we have required a pandemic requiring social distancing for us to come together in this unique way that we've come together tonight. We are planning to do a series of webinars that was intended to be clinical development, but these are going to be more than just clinical development. We're going to be trying to provide opportunities for training on advanced techniques, provide alternatives to opioids where appropriate, allow you to think about minimally invasive procedures that are coming to the forefront just now, and let you know what some of your partners are doing. As your partners are starting to do new and innovative therapies, it provides you an opportunity to look into the window of what's going on in other practices around the country. My goal in part is to also help you separate the wheat from the chaff. There is a lot of things that people are doing today, and I hope to provide you with a uniform approach towards what we should be doing. A second goal of this is allowing us to start to get some uniformity in how we think about things and the pain procedures that we offer. It is certainly not intended to tell you, be prescriptive in what you do with patients, but eventually there's probably one best way to care for patients. And by us all understanding what's going on in other parts of the country and other parts of our practice, that we can understand what we can do best to offer the best care for our patients. Much like if you go to a Ruth's Chris in Florida, you might get a great steak with some grits. You'll still get a great steak up in the Northeast as well. So the idea is to really optimize quality. The third aspect of this event is to really have some fun. And I recognize how hard everybody's working for 12 hours a day, and then to add on a few hours at the end of the day, some kinds can be onerous. But I think we're going to have some fun with this. We're going to do brief snippets, new topics for some people. And I think we have to do this. Unfortunately, when we all graduated, when I graduated from my program, there was no such thing as an interventional pain guy doing spinal cord stimulation. There was no thing as a pain person doing pumps. But the pain therapy has rapidly changed, and we're going to be getting off new topics every week about what do you think you need to know about your practice. And you know, today we're going to talk about minimally invasive spine surgery, from interspinous fusions to percutaneous lumbar decompressions and spacer technology. But other times we're going to talk about other types of complex procedures and allow you to evaluate the data and figure out what's real. Fourth, of course, you all need to get your CME, and we're going to be providing CME with this. And we're going to also learn about what our peers are doing. Lastly, we're going to have some topic that is a little bit just off CME. I mean, it's not going to be a huge amount of time, but we're going to talk about advances in our practicing in CDC, what's happening in the real world out there, what's happening with the FDA, what's happening with our fellowship with Dr. Sajan. And we're going to have other topics that are going to be really of interest to the practice. And it may be burnout or other types of topics that we're going to cover as well. But the focus of what we're going to try to do is IPM practice. For our first ever NSPC Developmental Clinical Series program, title came up by Bill Kolazar. I've asked Doug Weiser, our CEO, to provide some introductory remarks and his thoughts about the merger and where we're going as a field, and Willie with our combined practice together. So with that, Doug, I'm going to turn it over to you.
Thanks, Peter, and thanks for everyone joining on. I'm so excited to see now we have 88 participants. You know, if you just take a step back, it's easy to say, what are the pitfalls of getting big on an individual basis? Oh, we used to do this aspect better, or maybe I had more autonomy in this aspect. but so few times do we take a moment to really celebrate what are the pros of joining forces. And with 118 interventional pain management centers across 11 states with nearly 300 providers between physicians, nurse practitioners, and PAs practicing almost exclusively in pain management, this merger was almost like a shot of adrenaline into our organization on our side, because we had these ideas, we needed to get rolling, and it's almost as if the news of the merger really supercharged how we're, forging ahead with some of these great ideas we've had, whether it be advanced training with on-sites on weekends that had already just got started but now expanding rapidly, or whether it be CME for webinar series that everyone can participate, but in topics that are really focused in what you see day to day, but in kind of snippets that don't require a weekend away from your entire family where you're getting death PowerPoint. We can give you really strategic surgical strike of information for the glass of wine or beer and then sign off and be, that much further along in your career development. I can't say enough how excited I am about the direction we're headed. I have been talking a fair amount. I won't take up much time of this evening. I do have a pre-engaged meeting. I actually asked to step out from dinner and come out to the car so I could launch this just to see, more than anything, we're up to 90 participants. So there's a lot of great things ahead for us. The strategy is first and foremost integrating these two great companies, getting some consensus views around things like our current toxicology programs, physician-derived best practice and risk stratified testing recommendations, getting some kind of synergy out of the pharmacy component, whether it be workers' comp, mail order, internal, or compounding, and then deriving the growth and development of individual providers like we are doing with these talks tonight in the advanced procedure realm, giving everyone opportunity to expand their horizons. Because if you heard me say it before, and I stand by this, the idea that as an interventional pain practitioner that you'll just be doing facets and epidurals, while you may be able to do that in a network of doctors, of like-minded people, for those in solo practice, that's probably not going to be consistent with the evolution of our space and field. So the beautiful thing about being big is it allows you to pick and choose a la carte the things you do want to become experts in, and then refer to your partners, whether it be regenerative therapy or implantable devices, so you can opt in and out the things that interest you and are most applicable for your patients. So I can't say enough. I'm really delighted to be here. I can't wait to be part of this series, Peter. And with that, I'll turn it over to you guys.
Thanks, Doug. It's a pleasure to get us started here. Next week, we're going to have some new speakers. It's October 6th is our next symposium, and our roundtable discussion that will start will be with Kevin Miller, our chairman of the board, and Mark Coleman, our president. And speaking of our president, Mr. Dr. Coleman, Dr. Coleman is well known in interventional spine world and interventional pain management. I had the pleasure of meeting Mark when I think you were still a medical student at Hopkins at that time.
That's correct. That's correct.
Myself,
inspiration.
and Mark and I over the years have spent time working together on complex pain strategies, including the piled procedure, which he's going to cover tonight. And without any further ado, I'm going to turn it over to you, Mark.
Thanks a lot, Peter. Again, this is a very great experience for National Spine and Pain, and really kind of elevates our practice, and that we're able to disseminate such a rich content in a relatively compact manner to so many of our group of physicians. And I think that this is just the first step in something really, really great and evolutionary for our practice. So I'm really happy and proud to be, on the first program. My talk today is going to be on the piled procedure. Now, the first thing that came to mind when I had to speak about the piled procedure is like, well, what is piled? And piled is the general term for percutaneous image-guided lumbar decompression. that is the generic term. That is what it is listed under by CMS. Under that category of PILE, there is really only one example, and that is the mild procedure by Vertos. Okay, so I will use those terms, interchangeably, but one has to understand and recognize that there has been really an explosion over the past 10 years of the different ways that one can treat lumbar spinal stenosis in a minimally invasive manner. You'll hear other acronyms, and I'll just kind of, lay some of them out for you. PSLD, which is percutaneous stenoscopic lumbar decompression, or endoscopic lumbar decompression, which, quite frankly, I used to do before the malpractice insurance rates went up so high that it categorized the procedure as a neurosurgical procedure. There is also percutaneous disc decompression, which many of you may know as disc FX, or there was another procedure by Stryker called the Stryker decompressor. And those are all intradiscal procedures. So there's really a large menu of procedures that we use to decompress the spine. Last but not least is indirect lumbar decompression, which Vip will be talking about, and that is a totally different manner of treating, spinal stenosis. So just have to understand there are so many different ways to treat this disease. By way of disclosure, I am a board member and a shareholder of Axsome Pharmaceuticals in the headache and CNS space, Vertos Medical, Abbott Laboratories, and Omnia Medical. Let's go to the next slide. Okay, so let's talk a little bit about percutaneous image-guided lumbar decompression. Now, what this is not is a lecture to teach you how to do the procedure. This is the didactic lecture light, okay? So it assumes that you know a little bit about the mild procedure, but just by way of introduction, the mild procedure was designed to treat central spinal stenosis. Central spinal stenosis is typically caused by three phenomena that occur in the aging spine: ligamentum flavum hypertrophy, disc degeneration, and facet hypertrophy. And all three of those phenomena contribute to a narrowing of the central canal. Of those three, 85% of central canal stenosis is typically caused by hypertrophic ligamentum flavum. The mild procedure, or the PILE procedure, works by decompressing the ligamentum flavum. The important distinction between the mild procedure and other procedures that achieve this goal is that it really does not involve a full incision, and that there is no hardware left behind. So there are no spacers left behind, and there are no rods and screws like a surgeon would apply. Next slide. Okay, so who are the candidates? The candidates are patients with neurogenic claudication, and those can be simply identified by questionnaire. You ask your patient, do you experience pain in the back and legs when you stand? And you ask, well, how long after you stand do you feel it? And anywhere between a minute and 5 minutes, they typically feel these sensations. They typically get worse with ambulation, and it doesn't necessarily always present as pain. Sometimes patients say that there's a sense of heaviness, tightness, a vice grip around my calves. These symptoms typically get better with bending forward or simply sitting down or laying flat. The symptoms immediately get better. If you see those characteristics in a patient, then without even doing an MRI, you should be thinking about central canal stenosis. The second phase of diagnosis is to indeed get the MRI, okay? And the MRI on cross-section is going to show a triangular looking central canal. in a normal patient in the lumbar spine, the central canal is going to be circular on T2 weighted image. And in a patient with stenosis, it's going to be triangular or trefoil. That black area that's encircled by green, that is ligamentum flavum. Patients are candidates for mild when there's central spinal canal stenosis present, and when there is hypertrophy of the ligamentum flavum greater than 2.5. Many of us don't know how to measure ligamentum flavum. If your radiologist mentions hypertrophy ligamentum flavum, then the patient is a candidate. Next slide. So there are some contraindications to this procedure, and those are pretty simple. Patients where there's not enough intralaminar space to fit the tools. And I know that from the epidural steroid injections that I do prior. You can get a good sense to see how much space is there. One can also use a radiologic approach as well by looking at the mid-sagittal view. And as you can see in that arrow on the right-hand image, that shows that there is plenty of that black space there where one can fit the tools for the mild procedure. You also want to take a look at spinal instability. This procedure can be performed on patients who have spondylolisthesis grade 2 or less. If there's a dynamic spondylolisthesis, meaning that on a flexion extension film, you proceed with caution, but that being said, patients have shown no increases in spondylolisthesis with the mild procedure. Also, a contraindication is any prior surgery at that level that breached the lamina. So patients who've had laminectomies in the past or lami disc, those are not good candidates for the mild procedure. What's important when trying to select for the mild procedure as well is to expect radiologic comorbidities, okay? We have to understand that in terms of central spinal canal stenosis, you're only going to see pure central canal stenosis due to ligamentum flavum in about 5% of patients, okay? The spine does not degenerate preferentially to the ligamentum flavum. It's really the spine, each spinal segment is a 3-joint complex. So you're going to see associated lateral recess stenosis, some facet arthropathy. You're going to see foraminal stenosis. So all of these comorbidities are present, and patients have been shown to do well when they have these comorbidities as well. Next slide. So what's interesting about the mild procedure is that you know, it's really falls in our wheelhouse in the sense that many of the patients that we have in our practice that have central canal stenosis are also elderly. It's a disease of maturity. So along with that, you're going to see all the other comorbidities like poor bone health and osteoporosis. Those patients will have seen the surgeon and they'll say, hey, listen, you're not really a candidate for a decompression and hardware fusion because really I don't have anything to fuse to. The bones are in such poor state that I feel uncomfortable doing that. Also, you're going to have patients who have other medical comorbidities, whether that be cardiorespiratory disease, they're anticoagulated, a bunch of other different diseases, renal disease. And again, because the low profile of this procedure and the percutaneous nature, you can extend the cohort of patients that have access to the procedure because it really is so safe. That last square up top on this slide is indicates that in contrast to intraspinous spacers, one can treat L5S1 disease with the mild procedure. Now that's true and it's untrue. Recent advancements in intraspinous spacers have made the L5S1 level more reasonable to do There are different shaped spacers, which Vip will talk about. It's just that the S1 spinous process is usually rudimentary in most patients, and it's hard to, fix an interspinous spacer there, but it can be done. Next slide. So, long story short, the mild procedure, there's broad candidacy for our patients. Specifically, as I said before, patients who are unable to have or tolerate surgery, patients who have hardware at an adjacent level. That's a really important distinction there, because again, patients who are looking at interspinous spacers, there's really no interspinous process at a level where there's already been surgery. And oftentimes the surgeon is going to have to do a complete reconstruction in order to fuse to a level that's already been operated on. So really the mild procedure, it may be the only option for a lot of these patients. The second cohort are patients who are really in our nurse practitioner services, and they may be on light opiates, getting 1 or 2 Percocet a day, but when they get spikes of pain, they're referred back to us for epidural steroids. In everyone's practice, there are patients who have received just too many epidural steroid injections. I have done case studies and legal reviews for patients who have had up to 50 epidural steroid injections. And in this day and age, it's really unconscionable to have patients undergoing that many epidurals when we have alternatives. Next slide. Okay, so this portion of the talk assumes that you know a little bit about mild. I'll review it slightly. If you would like to learn more about how to do the mild procedure, we're going to be having a course in Florida shortly, and we already conducted a course in the Maryland, DC area in Virginia. So, but if there's any more, questions on how to do the procedure, getting access, please email me. But this portion, I'm going to talk a little bit about how the procedure is evolving. Next slide. Okay, so, the basic procedure is performed through a 5.1 millimeter access port. You use a trocar to place proprietary tools in the intralaminar space under fluoroscopy, okay? And using those proprietary tools, one attempts to do 2 things. The first is to create space in the intralaminar area by removing osteophytes and gaining access to the ligamentum flavum. Once one has more or less dug a hole to the ligamentum flavum, you use a proprietary tool called a tissue sculptor to scoop out pieces of ligamentum flavum and therefore debulk the ligamentum flavum and create some space there. It can be done at multiple levels and multiple sides. When the procedure is finished, it generally closes with a steri strip. I have never seen any significant bleeding in this procedure. The deepest portion of this procedure is when one does the epidurogram, which is something that we're all quite familiar with. Next slide. So when the procedure was first contemplated, it was taught in a way where each level and each side were treated individually. So for example, if someone had bilateral L4-5 central stenosis, one would treat the left L4-5 level first and then go and move to the right L4-5 level. If it was 2 levels, it would be 4 puncture holes. If it was 3 levels, it would be 6 puncture holes. The criticism of the procedure was that it took a lot of time and that the radiation exposure may be, may be going to be too much for early adopters. And if you didn't gain speed very quickly with the procedure, a lot of, there were some practitioners who dropped the procedure because they're just like, well, I really can't get this done fast enough and minimize the radiation. There have been some new modifications to the procedure using a midline approach that has, in studies, shown that we've reduced the fluoro time by at least 50% and the overall procedure time by a similar amount. So let's move. Next slide. So the key benefits of the Streamline technique is that there's a single incision in the midline. It produces reduced radiation. It's simpler, and there's greater predictability. Let's go to the next slide. Okay, so this is a radiographic image showing where the trocar is placed for the Streamline technique. And very simply, the trocar is inserted into the subcutaneous tissue at the level that's to be treated. And instead of going deep all the way down to the lamina, the trocar is moved to the side that one would like to treat while it is only about, half a centimeter deep in the subcutaneous tissue. So you're essentially stretching the skin and the subcutaneous tissues over to the side that you're treating. You treat that side, you withdraw the trocar again to the subcutaneous tissues and then move over to the other side. So with that maneuver alone, we've been able to reduce the radiation exposure and the treatment time. Next slide. So I'd like to kind of turn your attention to the body of evidence behind the mild procedure, because that continues to grow. The mild was approved as a 510K, meaning that the FDA approval came as approval for surgical tools, and how one used those surgical tools was up to the practitioner. But the procedure itself had data early on, but did not have the robust data that it has now. So over the years, the evidence is quite sound that mild is a very reasonable and helpful procedure for many elderly patients. There have been 2 level 1 studies so far. They're randomized controlled studies that are done in a very exacting, statistically relevant way. The results show long-term significant clinical improvement from the standpoint of pain, also long-term durability and functional improvement. The best thing is that, over all of the studies that have been done, and here I'm only talking about the 2 level 1 trials, but there have been something like 19 clinical trials right now for mild. Some of them small, but some of them bigger. But the safety profile is always the same. The safety profile is equivalent to an epidural steroid injection. So for all of those who hear about the mild procedure and get the notion that we're operating deep in the spine and this is the land of the neurosurgeon, it's simply not true. This is something that is within the skill set of all of our physicians. Next slide. And again, I mean, this is just a repeat of what I mentioned before. The Midas Encore trial was a trial of mild versus epidural steroid injection in 300 patients. You have to note that it wasn't just central canal stenosis. 5% of the patients also had other forms of stenosis, meaning lateral recess stenosis and foraminal stenosis as well. Let's move on. So the basic study results over 24 months showed that there was both improvement in pain scores by about 5 points on the numeric rating scale. As you can tell, the improvement came over the first 6 months, and then the improvement plateaus and is durable for 24 months. We saw a concomitant improvement in functional status as well. It's evidenced by the stress-free disability reduction of 32 points. So next slide. Also, the patient-reported satisfaction scores were consistent with the non-subjective data, and at 85%, patient satisfaction is really quite good for any procedure in the spine. The adverse event rate, and this is minor adverse events, was 1.3%. And those are events that are, due to device or procedure related. Either something broke down with respect to the tools, and in this case, this was basically a trigger on the tissue sculptor got stuck, and they had to replace it. That's not a real adverse event, but it does. One has to, to report that in a study. So it's not really an adverse event, but it's something that happened. The safety profile, again, equivalent to an ESI. No spinal instability in those patients who came into the study with grade 1 or grade 2 spondylolisthesis. Next slide. This is the Cleveland Clinic study. This was about 80 patients done by Nagy McHale up in Cleveland Clinic, and looked at different functional indices from the previous study that I mentioned. Here he took a look at really what the patients complain about, and it's really standing and walking times. And here patients came in with a baseline of 8 minutes of standing tolerance, and over the course of 12 months increased to 56 minutes. And with respect to walking distance, they started out with, and I'm looking at a screen so small that it's hard to see the number, but 300, and it went up to close to 4,000. So very significant improvement. Again, this is a recitation of the adverse events and risks to mild. As you can see, there's very few. And when you put them in comparison to other treatments for central spinal stenosis, such as interspinous spacers and surgical decompression and fusion, you can see that the reoperation rates, the minor adverse events, the serious adverse events, there's really not much of a comparison. Again, the mild procedure is very safe in the hands of trained interventional pain management physicians. Again, this is just repeating what I'd said before. The safety profile is equivalent to an ESI. So next slide. So the clinical summary here is that we've got a procedure that is minimally invasive, easily done by interventional pain management physicians. We have the common treatment in our hands, which is epidural steroid injections, which really lose their efficacy over time. So we need to, kind of take a look at what we're doing here and see if we can reposition mild perhaps as a better treatment for spinal stenosis. Next slide. Running out of time, Peter?
Running out of time.
Okay. Well, listen, I will go quickly through this next slide, this next couple of slides, and we'll wrap up. So the notion was that, hey, listen, we have a lot of patients who are in our nurse practitioner services who are getting ESIs for spinal stenosis. why not just simply go straight to mild when we see the radiographic evidence of central spinal stenosis? Next slide. So there was a study that was recently performed by Peter Pryskowski and Jason Rosenberg, a two-center study where they looked at just this. They compared a group of patients who had previous epidural steroid injections to those who've had just one epidural steroid and gone straight to the mild. Next slide. As you can see, there's really no difference. So the idea of the cumulative effect of epidural steroid injections is really kind of a misnomer according to this study. So this evidence may back up the notion that maybe we should be using mild earlier in our algorithm. I'll close with that, Peter.
That's great. Thanks,
All right.
Mark.
Thanks.
That was a wonderful introduction. And I think part of the goal of this was understanding that epidural steroid injections really do lose their efficacy for a lot of patients. And we're going to talk about the next iteration in this. And we're going from Hopkins Medical School to Hopkins Fellowship with Sean Lee. Sean Lee, I was fortunate enough to have Sean join me 10 years ago. Is that about right, Sean? Was it 11 years ago now?
I think it's 10 years this month.
But who's counting, right? And he's going to talk to us about the next iteration for spinal stenosis with spacing and some of the pros and cons of spacing, which was not really part of our practice 5 or 10 years ago. So again, I'll turn it over to you, Sean.
Thank you, Peter, so much for giving me the opportunity to share this talk with a group of great colleagues here. Today, I'm going to talk a little bit about spacers, and absolutely, I think the best way to describe it is, these treatments fall into a spectrum of care that we can offer to patients with spinal stenosis. And I can remember quickly after joining you somehow got me trained for the mild procedure, and 2 weeks ago, I did it on a 94-year-old lady who came in on a wheelchair, and she was quite nervous when she was about to get sedated. And the anesthesiologist, we both know, leaned over and said, "Don't worry, you're going to do just fine." Peter and Dr. Stats and Dr. Lee did this on my mother 8 years ago. She's doing really well. And she ended up having about 75% pain relief. So we always have to keep in track of what is the best treatment for our patients. And it may not just be the one thing. So today we're going to talk about a little bit about pathophysiology, which Dr. Coleman already done so. Going to review some clinical presentations of spinal stenosis in terms of diagnosis and in terms of imaging. And then we're going to review some evidence regarding the spinal cord, so the interspinous spacer placement for this lumbar stenosis. So here is the brief outline. I'm going to finish off with talking a little bit about some billing and coding of these spacers as well. So I know we have a time limit, so I'm going to kind of go through this and be efficient. So as Dr. Coleman mentioned earlier, spinal stenosis is a culmination of various degenerative conditions, but it results in more than 50% of the time lower back pain, and is classified as a disabling condition by the Social Security Administration, and has a large prevalence. So if we look at this study done by De Villiers of 850 milligrams, it's about 6% prevalence, and it's over $100 billion a year cost due to productivity loss. And it often ends up with a manifestation of pseudoclaudication, meaning pain down the legs with walking and standing, alleviated with sitting and forward flexion, and preventing folks with being able to walk and ambulate, especially for our elderly population. This takes away their freedom. So natural history, we know that there's a combination of a degenerative cascade of not just one thing, but multiple things that happen in the spine. Disc degeneration, loss of height, there's osteophyte formation, facet degeneration, buckling of the ligament, which can be now decompressed with this mild procedure. And obviously, it all results in tightening of the spinal canal, which results in the symptoms that we're here to discuss. So in the spectrum of care, there's a large population of patients that are diagnosed, and the treatment algorithm has certainly changed and moved a little bit away from surgical decompression, but with a little bit more emphasis on intervention, and still not forgetting that there's a myriad of conservative options that are available. So patients who were in pain practices being treated for opioids and possibly epidural steroid injections who fail in terms of longevity now have the opportunity to undergo these minimally invasive procedures, and one of which is the interspinous spacer that I'm going to talk about today. So this is the classic shopping cart sign. So patients don't always complain of pain. So when you ask them, well, where does it hurt? And they say, well, doc, it doesn't hurt, but I can't walk. I get cramping, I get weakness, and sometimes a tingling sensation in the legs when I stand. But as soon as I sit down, everything gets better. So we're looking for this phenomenon of intermittent neurogenic claudication. And you really have to play that into part of the diagnostic procedures, because we want to make sure we differentiate this with the standard radiculopathy. In terms of the diagnosis, there's really a gold standard, but we need to verify that there is spinal canal stenosis or foraminal stenosis on imaging. We want to take a thorough physical exam and history. There's key factors in the workup. You want to make the distinction between radiculopathy and neurogenic claudication. Obviously, keeping in mind that there's a whole sort of component of other things that are degenerative in the spine that comes in play, such as spondylolisthesis. MRI is always preferred, but a CT scan will also work. You want to obtain flexion extension films to rule out instability, as Dr. Coleman mentioned earlier. And in some ways, you want to sort of record down, and in terms of now these days, we're all looking about functional outcomes. You want to know how you're improving the patient's outcomes in terms of Zurich claudication scores and Oswestry disability indexes, in addition just to pain scores. So these are some of the questionnaires. We have them incorporated in our intake sheets, and if you haven't done so, I suggest definitely, because some of these questions may be able to just guide you to your patient's diagnosis. I only add this next set of slides because I wanted to kind of showcase just the spectrum of care. Obviously, you can recommend patients to exercise and change their lifestyle, but oftentimes this comes too late when patients become symptomatic. And so now you can incorporate conservative things like physical therapy and rehab, but really their data has not been shown to be very effective, but they can act as adjuncts, especially after the surgery or after the procedure, to help recondition their spine and essentially reintroduce the concept of walking upright for the patients. And we all know about medications. Some have high side effects, some are no longer considered safe, and obviously they're ineffective. Otherwise, we wouldn't be talking about these interventions right now. Injections, overall, there hasn't been a great supporting evidence in the treatment of spinal stenosis specifically. Most epidural steroid injections have been incorporating radicular symptoms as a whole, and they do have some evidence. And I still incorporate the use of epidural steroid injections for spinal stenosis for various reasons. One, you definitely want to be able to offer that as an initial therapy for patients. It helps build a relationship with your patients and trust. But also when I do the injections, I'm also getting additional fluoroscopic views to see what my access points are, whether or not this patient be good for, say, like a mild procedure versus an interspinous space replacement as well. So in terms of surgical treatment, well, if everything worked, then there wouldn't be any spinal surgeons. But the data for decompressive laminectomy, which is somewhat considered the gold standard for spinal stenosis, is poor at best. So most of you can recall that there's a sport trial, which essentially says at 4 years, there's diminishing benefit compared to conservative therapy. So patients who get a laminectomy may not get long-term relief as much as they think they're getting. And it's becoming an increasing surgical option for Medicare patients. In fact, between 2000 and 2007, fusion rates have increased 15-fold. That comes along with complications as well as the cost. So now, Dr. Coleman mentioned about debulking the hypertrophied ligamentum flavum. And I also wanted to include this slide because it falls into the spectrum of care in terms of patients who suffer from spinal stenosis. It does have excellent data, And I was very proud to be part of the Midas Encore study that you and Dr. Benjamin, both at NSPC, led in which, in fact, this was a study, the landmark study that got our coverage back in terms of reimbursement. So let's dive a little bit deeper into interspinous decompression. This is a posterior approach. So various spacers have been introduced to market, and some are no longer on the market, but this is FDA approved for spinal stenosis leading to neurogenic claudication. It's also approved by Medicare with positive reimbursement profile. It's not an expander, but in fact, it acts as a backstop to prevent compression of the spinal canal when patients stand and walk. It does have level 1, 5-year evidence. It is very minimally invasive and an alternative to open surgery. Another positive remark about this is we do have level 1 evidence that shows that it may help patients reduce their level of opioid intake. So not only are we talking about improved function, but we're also talking about reduction of opioids. So again, in a graphical form, you can see that when patients are flexed, their spinal canal opens up a little bit. So this is an example of when patients sit down or lean forward or lean on a shopping cart. But when they stand in an extended format, their spinal canal narrows and the ligament flavum buckles in and causes symptoms. So what this device does, as you can see in the right panel, it acts as a backstop. So there isn't any compression of the spinal canal at that segment, and you're acting as a blocking device to prevent stenosis, hence relieving the neurogenic claudication. So this is a brief sort of description of the procedure. Essentially, it's a fluoroscopically guided procedure done with approximately a centimeter incision midline posterior to the spinous process. Once an incision is made, it's done over serial dilation over a guide pin, and then serially dilate a tube, which allows you to insert and deploy a titanium device that snugs itself between the two spinous processes. Usually the patients are closed with either one stitch or not at all. In my case, I only use glue, and these are all outpatient procedures. We may be able to make this work. If not, it's okay. We'll go on. Let's move on. For the procedures, certainly there's animations available on the website. So let's talk about data. The 5-year IDE study, the patient population and data sets that were extrapolated also included opioid information. So at 5 years, 85% reduction in the proportion of subjects using opioids. And I cannot emphasize more on this in terms of being able to reduce the intake or the need for opioid intake in an elderly population is quite valuable. So we're not only able to provide functional relief, but we're also able to reduce opioid intake. So let's talk about some of the other endpoints. So this was the primary endpoint in the 5-year IDE study. We had reduction of the Zurich claudication score up to 5 years. 75% of the patients had reduction of the ZCQs, which is quite remarkable and sustainable over 5 years. Some of the secondary endpoints, visual analog score, pain scores, were also reduced and maintained over a 5-year period. And then this is the data regarding the opiate reduction. So looking at all the studies available to us, here on the left, you can see that epidural steroid injections do have their role in treating spinal stenosis, but their results are not only less effective, but they don't have the duration and longevity of something like a minimally invasive interspinous decompression. Here you can see that the mild procedure is also included, and it has impressive results. And keep putting, putting everything on the same scale. Laminectomy may not be as efficient as we think they are. This is an interesting set of data that we presented this at the NANS conference last year. And big shout out to my current or my new partner, Chris Bovenet from Prospera. We were involved in compiling a set of data on patients who've had previous stimulator implanted with spinal stenosis. So as all of you know, that prior to these minimally invasive procedures, we were using spinal cord stimulation as a therapy for spinal stenosis. They worked in the beginning, but as the stenosis progressed, their therapy, their efficiency of therapy reduced. So we thought by combining the two, patients actually were able to regain their treatment. But what's also interesting to find out in this study is that of the about 25 patients, about 81% of the patients who were reporting opioids in this study or this series, only 13% or 4 patients were using opioids after the placement of these spacers. I apologize for the small text here. And this is a little bit of a real world information. So after this device was introduced, we performed a registry study, this press data, which was all of the practitioners who were placing these interspinous spacers. And we looked at not only their efficacy, but also their safety. 2 things we noted. We were able to reproduce the same efficacy as the IDE 5-year study. But what was also interesting that the level of device migration and spinous processes fractures, which was mentioned in Dr. Coleman's lecture, was significantly reduced. And part of the reasoning for that is the actual procedure has been modified so that the spacers were placed very tight, hugging against the spinal laminar junction. This reduced the number of migrations as well as fractures. And as a shout out to all my interventional colleagues who did this, this was a group of interventionalists who were doing this rather than surgeons who were doing the initial IDE study. So I'm going to leave that without any interpretation. So coming to the end of this talk, kind of want to give you this is a very complex weave of part of the MIST guidelines, which is a published algorithm by Tim Deere, helping us to how to protocolize treating patients with spinal stenosis. By looking at this, it seems quite complex, but it's actually very simple. And if you take away most of this stuff and get to the next portion in terms of treating somebody who has symptomatic refractory spinal stenosis, you start with a physical exam, imaging studies. You want to perform flexion extension films. If the patient has significant amount of ligamentum flavum hypertrophy, along with the other criteria, less than grade 2 spondylolisthesis, you may want to try a mild procedure first. If the patient does not have a ligamentum flavum hypertrophy and has less than a grade 1 spondylolisthesis, or if you've already tried a mild procedure on them, you can definitely consider performing an indirect interspinous decompression on them. The limitations comparing the two is that this device is only indicated for L1 through L5. You're unable to place a device between the L5 and S1 segment because of the lack of the spinous process for obvious reasons. So finishing up in terms of billing and coding, for patients who are diagnosed with lumbar stenosis with neurogenic claudication, so I repeated the ICD-10 code there, but that's the ICD-10 code, and the insertion of an interspinous process distraction device posteriorly without any open decompression or fusion at a single level, and here's a second level, can be used. So this is indicated for 2 contiguous levels. Sometimes you can either place 1 or 2 levels at one sitting, and if you decide, you can always go back and add another second level if you choose. And sometimes if you need to add a 3rd level after a 90-day universal period. So to wrap up, we know that spinal stenosis is a major health issue that's among the chronic pain health, I guess, epidemic as well. So we had an opiate epidemic, used to be #1 health crisis prior to COVID-19. We're dealing with an aging population, approximately 14 million patients suffer from symptomatic lumbar spinal stenosis, and 2 million people are in treatment, but 94% experience neurogenic claudication. And we now have evidence-based interventional treatment options that can provide an alternative to long-term opiate therapy. So I would definitely, one takeaway is definitely want to pick up that article on the MIST guidelines for additional resource if needed. And with that, thank you for your attention. And I'm looking forward to hearing Dr. Mangel's talk.
Thanks, Sean. At this point, I'm just going to mention that there is after Dr. Mangel's talk, there is going to be a slide that tells you how to claim your CME. You'll have 48 hours from the moment that Dr. Mangel stops speaking. So he may want to talk a long time, but 48 hours from the time that he stops speaking to claim your CME. If you guys have questions that you want the panelists to answer, please chime in. And I have one question that I want someone to put in the chat for me. How many practitioners are there, NPs, PAs, physicians, in our pain practices, combined pain practices? First person to put the right answer in with me, or even close, gets a prize. So with that, I'm going to turn it over to Dr. Mangel. We're having a Hopkins reunion today. Dr. Mangel did his undergraduate degree at Hopkins, chemical engineering or something. I don't even understand what he was working on at the time.
Biomedical engineering.
Later trained at both Rush and UVA, and is now runs our implantable program for the Virginia NSPC branch. So with that, I'm going to turn it over to my good friend Vip and ask you to talk about what I think is yet the next iteration of interspinous lumbar fusions for chronic pain and spinal stenosis topics. So, Dr. Mang.
Yeah, so I mean, I think this is very controversial. I mean, to be honest with you, and I always, you know, when we were doing fellowships, I couldn't imagine doing half this stuff when we were coming out. And to be honest with you, 20 years ago, pain docs weren't putting in stim implants or pump implants, like Peter said. And so, you know, times have changed. Most stim implants, pump implants are put in by pain physicians now. And we would have never thought about doing mild. We would have never thought about doing interspinous spacers. And, you know, we would have never thought about doing SI joint fusions. I mean, all those things are all revolutionary. And this is, I think, the most exciting time in the last 5 years. And, you know, been doing this interlaminar stuff and decompression stuff for the last couple of years. And the biggest thing I always thought was, man, what was I doing to these patients before 2 years ago? Like, you know, think about it. What were we doing? What were we doing to some of these patients? We would, like Mark said, we would epidural them to heck, and then we would stim them. And that's what I was doing. I don't know about you guys, before I learned these procedures or were aware of these things. And so, you know, times have changed. And the real question is, how can a pain doc do a lumbar fusion? Right, because that seems crazy. And so I dived into this about 6 to 9 months ago and see what is it that composes lumbar fusion, and what is it that we can combine with this technology of using a minimally invasive lumbar decompression versus a spacer, and combining the two, and how do we and making it more stable. As you guys know, there's insurance things involved too, because Medicare's picked up on piled and Vertos, and Vertiflex, but it hasn't. The other commercials haven't followed, and hopefully they will with as the times change. So, what is interspinous decompression? So, you know, who are the candidates for this? So, I think Peter and Mark have gone through it at length, right? The key to this is we're doing this on the same patient population as we would do interspinous spacer. It's because it's on label for lumbar disc degeneration. So I want to be specific on that. These devices that I'm going to talk to you about the on label is intervertebral lumbar disc degeneration. It's actually indicated from T1 to S1. And so my secondary thing is who you should be doing it on is people with lumbar disc degeneration and also spinal stenosis with the posterior diseases. They've talked about facet hypertrophy, ligament plate hypertrophy, foraminal stenosis, and it's actually on label for spondylolisthesis as well. And patients with neurogenic claudication, the same stuff that we've been talking about this whole hour. So again, you know, with the things, what comes first? We don't know. Is it the disc degeneration? Is it facet hypertrophy? Is it ligament plate hypertrophy? So we don't know. And so it's what it's on label for is intervertebral lumbar disc degeneration. And so the patients I think that are more applicable to this are, you know, our spinal stenosis patients. And this is just a cross section. And these guys have gone over it at length. So, you know, again, I won't really go through it over and over again, but central canal stenosis, and I can tell you the biggest thing that they really gone to is really paying attention to the MRI, because that's really where everything is. And you got to really look at the central canal stenosis, the neuroforaminal stenosis, and the facet hypertrophy. Not only looking at a sagittal view, you want to also make sure you look at an axial view at your patients, because they clearly will have this. And I promise you, you know, before we were so keen on using it, looking at MRI reports, it's a very good position. You should be able to read an MRI of a lumbar spine. You should be able to pick up lumbar spinal stenosis, because sometimes people get foraminal stenosis without central canal stenosis, as you guys are aware. So picking this up on both the sagittal view and axial view is very important. And reading your MRIs and seeing why these patients are having these symptoms of back pain and leg symptoms, and what can we do about them? Because you can imagine this patient on the right with severe central canal stenosis L3-4. You can understand why a neurosurgeon is going to laugh at you if you say, well, I did a, you know, bilateral L3-4 transfemoral, because you're not changing the symptoms. You have a cord compression. It's like having a nail stuck in the bottom of your foot and doing a nerve block for that nail, but you still haven't taken the nail out. Because that's what I tell my patients is you have something stuck and it's compressing the spinal cord. And so what can we do about it? So how does a lumbar fusion work? The idea is putting a device like this, which, as you guys have seen, looks very similar to Vertiflex. So how is it different, right? So what makes this so different? The difference is going to be the stabilization of it. There's the devices are out there. They have these claws that bite into the spinous process, which fixates onto the spinous process. And you're actually putting bone graft in the middle of all these devices that is going to help with interlaminar interspinous fusion. It's a bone graft that's key. You have to put bone graft to actually get a bone infusion. So you're actually using instruments like something like Cobb, which, you know, some may not be familiar with, but it muddies up the bone so you can get an actual fusion. That's the difference. It looks as a very similar profile as a interspinous spacer. But the difference is we're adding bone graft and we're actually fixating it to the spinous process and the lamina, making it almost impossible for it to migrate, and the decrease of spinous process fracture dramatically because it's actually fixated to the spinous process. So that's the difference in it. So the key is the difference in this is the procedure is vastly different, both from, it's a combined, I call it a combined mild and interspinous spacer. So you're going to identify the space. This is not a heavy floor procedure, by the way. And the key is to, the 90% of the procedure is actually, if you guys ever done stimulator or pump implants, you know that you got to dissect down to the fascia before that's where you would anchor. So your spinal cord stimulator implants, you put those anchors, you anchor to the fascia because that's the most secure, most stable place to anchor the actual anchors to. So the 90% of the procedure is dissection to isolate the spinous processes. And you go down the fascia, if you go down the fascia, just like you would do a stimulator pump, you would see, you can feel the spinous processes. So just going a little bit further and dissecting around the spinous process. The reason you're dissecting around the spinous process, and I'll show you the pictures in a second, is because you're creating room for the spacer, essentially, right? So there's, on each side of it, you were creating space inside so you can actually put it in. You're actually looking at the spinous process yourself. And that might seem scary. I promise you it's not. you're actually doing an interspinous ligament dissection because the barrel of the actual implant goes between the spinous processes. And so you're taking the interspinous ligaments out with a bone rongeur. And then the next step is doing a decompression and using a kerrison, which is actually what the bone rongeur is in a mild device. You're taking a kerrison and doing the decompression with doing a hemilaminotomy of the actual lamina and the ligament flavum hypertrophy that also exists typically in patients. This is optional, you don't have to do it, but most of these patients with spinal stenosis also have some form of ligament flavum hypertrophy. So you can take a kerrison device and do a hemilaminotomy, and do a decompression at the same time, with a small kerrison. So it's not a true laminectomy, and so it's not the complications associated with that. And then you're actually putting the spinal insertion spinous device in, putting bone graft in, and you're putting bone graft on both sides of the interspinous implant. So this is actually an implant that I did. Actually my first of these that I've done. This was 6 months ago maybe that we did, was of what it looks like. And if you notice here specifically, if you notice these claws, so see the difference? There's these articulating claws that go right into the spinous process. So once you grab and when you collapse that spinal implant onto the spinous process, these claws are going to actually dig into the spinous processes on the superior and inferior spinous processes. And so you can imagine the fixation you're going to occur. These things can't move because I can promise you, by the time you put that implant in, it's just not moving because you're fixating into spinous process with these claws. Now, what's in the middle is bone graft. This bone graft actually is permeable to these holes. You'll see in the middle, it actually permeates out. And so you're actually, you got to be clear when spine guys do lumbar fusion, you might not be aware, they muck up the bone with something called a Cobb instrument. And I Google it, but basically all you're doing is having that bone bleed, and you want that bone to bleed because that bone graft is going to help make it grow. And it's this bone graft material that is actually creating the fusion. My first time ever touching bone graft was when I was doing this. The only time I ever saw it was back in residency when I was doing anesthesia and watching a spine guy put in bone graft. But it just feels like putty at the end of the day. They're like little flakes, and you put it in the barrel itself. So if you can see here, about 1 cc of DBM bone graft is actually put into the middle of the spacer. And you can see it out here, how it will permeate out over time. So with the claw fixation and with the bone graft, that's what's going to create your fusion. Now remember, we already did, by the time we're putting in this step, we already did the decompression and hemilaminate, same type of procedure with the kerrison that you would do with a mild procedure. So that part is already done. So what is our incision line? This is more invasive than mild and the interspinous spacers that Mark and Sean talked about, but just a little bit more. I'm a big implanter, so incision size is not a big deal to me. The idea is to take, and the incision size from the superior part of the spinous process to the inferior part of the spinous process. That's your incision size. Now, you can imagine the incision size is about 2 inches. Now, is that less than a centimeter or less than a baby aspirin? No. So if you're scared to make this big incision, this procedure is probably not for you. But if you're not afraid of it, as we do for stims and pumps all day long, this is not that big of a deal. Don't be afraid of incision size. It's actually about the outcomes. And the reason that the incision size is because you want to create room for the spacer. And so that's why the incision size is what it is, from superior to inferior. So we're actually looking at the spinous process. So if you can see in this picture, I've dissected down to the spinous processes, and then you're actually looking at it. Now, when you're actually looking at it in person, it doesn't look like this white material that we see in a graft. It's like a red material, and you can feel it. You can feel the bone, and you're actually looking at. This is why it's not a floor heavy procedure, because you're actually looking at the spinous process itself. You're looking actually in the interlaminar space itself. It's this space right here in the middle that you're creating with a bone rongeur to create space for your implant. So you're taking a bone rongeur after you've dissected space around the spinous processes on both sides, and taking away this interspinous ligament. And actually, osteophytes are in the middle as well. And after you create enough room, that's when you're putting the spacer in. And you can see how the claws dig into the spinous process. So that's the difference in this versus mild and vertiflex. And as you can see, this is the X-ray image of it. So you can see the claws on X-ray, you can clearly see it, and the bone graft is in the middle, and you created room in the middle for it. So can you do it multi-level? Of course. Most patients I've found I can tell you most patients either have L4-5 stenosis or L3-4 stenosis, or one of those two, L3-4 and L4-5. Now some patients have L2-3, but it's not very common. And L5-S1 typically doesn't even cause neurogenic claudication, I would argue, in my mind. So actually the first patient I did it in was a patient I put a pump in. If any of you guys recognize the pump catheter anchor, about 7 years ago, who just had back pain, failed MBBs, failed RF, failed stim, and was on opioids. I put a pump in, got off. He did really well for his back pain, came back. This guy was 86 years old. And all of a sudden, severe leg symptoms, severe neurogenic claudication, couldn't walk, was in a wheelchair. And so repeat MRI, he has severe stenosis. And so we put this in literally a week later, he's walking into my office. So that's the difference. And I will argue this is the same type of data that we will see with vertiflex and mild and those type of things. This can be done for adjacent level, although this is indicated for that, but I'll tell you, it's very rare that you can have even the spine process in sometimes, because usually when spine guys will do adjacent level Zs, they will have done a full laminectomy. But I haven't done an adjacent level segment due to fusion, but all the time I've done a 2-level fusion using this all the time. So the disadvantages is you got to be able to know how to operate. You know, you can't be afraid of it. I can tell you, if you never operated ever, you know, this just going to take some time. If you never wanted to ever implant your own stims or pumps, or you just didn't want to do anything like that, maybe this is not for you. Just know that this is an advanced surgical procedure. So this is the real deal. You know, it requires skills, and there's a lot of training. For example, in Maryland, Virginia, we're making sure everyone does at least 5, if not 5 to 10, with me before they're able to kind of go off on their own. You should develop some type of protocol for learning this, because this is new stuff. There isn't established courses out there for you to learn this. You know, we did this course in DC, Maryland, Virginia. We're doing it again in Winter Park, Florida. You know, these are small companies that have these, and they're growing exponentially. But you know, it's you know, you're lucky, I will tell you, at National Spine and Pain, to have these opportunities available. And so because these are being very limited and very few rollouts. And so, you know, if you come to Winter Park, Florida and see this in person, I'll tell you, you will not regret it. It's a really cool procedure. Incision size is bigger. I mean, obviously that's increase the risk of infection. All the ones I've done, I haven't seen any infection. I've done probably, I don't know, 30 of them. Now the difference is the biggest disadvantage, I think, in my mind, is just a malpractice increase associated with this, because this is actually considered a neurosurgical procedure, because you're actually billing for a 22612, which is a single level lumbar fusion, and you're billing for hemilaminectomy of 63030, and so it's actually a neurosurgical procedure for now, and there's a malpractice increase associated with it. Although I'll argue it's not any more different. I don't want you to be scared. There's no risk of epidural hematoma. There's no risk of spinal cord injury, because you're not deep enough. That's the biggest question. And you're looking at it, when I was looking at this, I was like, man, am I hurting this patient? Like, when I'm putting this implant in, am I too deep? And you look at it and you're like, you're not too deep. You're here. There's nowhere in there that you're going to hurt the patient. You're not deep enough. There's no risk of spinal fluid headache. We're not doing a needle insertion or anything like that. So the risk of the surgery, I tell patients, is bleeding and infection. Spinal cord injury with this would be extremely difficult, because you're not anterior enough for to hurt the patients in the interspinous space. Same thing with vertiflex. You're not deep enough for that to cause those symptoms. So so that's essentially what it is, and you really have to learn this in a cadaver lab. And so, you know, it's coming to you, and I know it seems scary, and so hopefully some of you guys think it's really cool that we can do stuff like this. But there are more and more people doing this, and there are 3 different implants out there. There's one with Aurora Spine, zip lumbar fusion, which is what I typically use. There's one called Stable Link, that has a lumbar spine, and there's also Minuteman, which maybe you have heard of as well, that has similar profiles. And so it's growing. And so, thank you everyone for joining me and joining us. And I'll leave it to Peter to ask any questions that anyone else would have regarding all our presentations or anything like that. So.
Great presentation, Vip. I appreciate it. We have time for just a couple of minutes for questions and answers. And so please call in with your questions if you have one. And if you don't, I'm going to get the guys started. I don't know if Mark is still on, or I know that he was going to have to jump off video, maybe on.
I'm still on if you can hear me. I'm driving, but
we can hear you. No problem. So if you have a patient with L4-5, central stenosis, but also foraminal stenosis, spinal stenosis, neurogenic claudication, how do you decide, of the 3 therapies offered today, what do you want to do next? I'll start with you, Vip. You got to go last.
Well, so I always try to, as Mark and Shauna mentioned, people get spinal stenosis for always multi-level stuff. And so in my mind, it's always multi-level disease. And so I always assess, if those all 3 are going on, especially people with spinal stenosis, we typically, when I see them, by the time we see them, they have moderate stenosis or severe stenosis. If they have mild to moderate, then I would, tend to perform the epidurals and mild. If they have moderate to severe, I personally I always do the interspinous lumbar fusion, but because I think the outcomes will be the same. And I'll tell you the one disadvantage I didn't mention in our spine is we don't have this great 5-year outcomes data that Sean and Mark have been talking to, because it's very new to the field. It's not even mentioned on those things, and we're actually launching a study very soon to get that data. And I suspect it's going to be probably similar to vertiflex. I don't think it's going to be that much different. But so it all depends on degree of stenosis. If it's mild to moderate, you might consider mild first. If it's moderate to severe stenosis, neuroforaminal stenosis, hypertrophy, I would consider interspinous spacer versus or doing an interspinous lumbar fusion. So I don't know what you thought on that, Sean.
How about you, Sean?
Well, I think you have to take into the patient specifics. At L4-5, all of these applications may work, but obviously we have to make sure that we're treating intermittent neurogenic claudication. This is something that would resolve when they're sitting down and leaning forwards. We want to make sure that you've ruled out listhesis or instability. But I think the best way to approach it is to follow these guidelines and to be algorithmic about it. Whatever you do it consistently, right? And have the patient's best interest in mind. So in certain patients, like this 94-year-old, she was not a candidate for any more invasive than the mild procedure, because it's nothing in short of just, it's basically an epidural injection. And I don't think she would have tolerated a more invasive interspinous spacer. But then in patients who are a little bit younger, a little bit more active, I may want to do something more definitive, such as an interspacer spine spacer, or I would have to fall back on data, and I guess if the fusion device does come up with data, I would definitely be more interested in trying that on my patients as well.
How about you, Mark?
I would echo what Sean is saying, and you always go with the patient profile. We don't necessarily treat MRIs, and we don't necessarily, guidelines are guidelines, but we have to understand that these guidelines are going to be inherently flawed because they're meta-analyses, and they're not really head-to-head studies of one method, one treatment modality versus the other. So for me, I always go with the patient. If sitting down and they're talking to me, they say they have leg pain that's going all the way down to the foot, then I know the foraminal stenosis or the lateral recess stenosis is predominant. And although the mild studies do show that it is possible to treat that with a mild procedure, it's certainly not intended to do that. So I'm thinking that the patient is going to need a more formal, decompression, and that can come in the form of a percutaneous form like Vertiflex, or if the patient is, physiologically robust, you can do the Aurora Zip procedure. Similarly, one thing that we didn't talk about is facet arthropathy, because that's really a big component of elderly patients' pain. And to the extent that you have patients who have pain that is largely manifested in the back, immediately when they stand up, there's going to be a facet component. And one thing the mild procedure doesn't do is unload the facets. So I always think an indirect decompression, and for patients who are back pain predominant, heavier, not Medicare age, because the Aurora spine is patients are eligible with any age. I'm thinking more of a more of a sturdy decompression with a spacer like an Aurora spine. So that's kind of how I tease it out.
That's great. One of the thought processes that I was thinking about during your lecture, Mark, in particular, was I once was consulted about a malpractice case where the physician who was the expert for the plaintiff claimed that you shouldn't be doing a mild procedure in a patient who has foraminal stenosis. And your point was really well taken. When Ramson and I conducted that study, the 2-year outcome study, we went back and we looked meticulously at the predictors of success. And interestingly, not only was the 95% of the patients have some other pathology, either a disc bulge, a facet arthropathy, or have something else, degenerative spine disease, there was actually a positive predictive value of having something else and doing well with central stenosis. So it was just kind of an interesting aside. And I was on the side of the defense of that doctor. And the plaintiff's expert really just didn't know what they were talking about on that. They just completely misinterpreted the data and said it can't work, but never actually read the paper. So to that, that's an interesting aside. We're about ready to wrap up. So I wanted to thank, first of all, the 3 of you guys for lecturing tonight at our inaugural lecture. And you will all be receiving, if you send me an email, a very special National Spine and Pain OGO backpack with our logo on the front that you may see here. One team, one mission for your lecture tonight. But you have to send me your home address on an email that I can forward on to someone else to actually do the work. So thank you for that. And our winner tonight, and this is kind of like Jeopardy. We're going to have somebody cross-reference the answer. But as best I can tell, it's Tabitha at coming in with a guess of 300. And the actual number that I calculated was 288 to my question earlier tonight. So Tabitha, my name is Peter Stotts, and I'm pstotts@treatingpain.com. Send me your address, and unless there is a late night call, which you'll still win, a backpack, you're going to get the same prize as the speakers did tonight. So thank you for joining in to the question and to the game portion. Now to end up tonight, we're going to continue to do this. Our next one is scheduled for October 6th, just a week away. And that was an error on my part. In the future, we won't make them every week, but I would like you guys to email me or communicate somehow on how frequently you'd like to see these events happen. In addition, I'm looking for volunteers, as my teacher used to say, who gets to volunteer to come to the chalkboard? And if nobody volunteers, I get to put people in there, but I'm looking for new volunteers to come in and volunteer to give a lecture on something that you think would be of interest to the group. And I have a list of things getting started, but We're going to try to make it thematic. We're going to try to keep things moving. And I'd love to have you guys come. Again, next week, we are going to have Louis Fandos. He's going to be giving a lecture. We have one lecture to be determined. I'm blanking on our third lecture. Oh, it's Anish Patel. It's going to talk about SI fusions and diagnosis of SI joint disease next week. So we're going to have next week. And again, Kevin Miller, our chairman of the board, and Mark Coleman are going to talk about something very close to my heart, which is do the right thing. We're going to have a wonderful presentation next week. So with that, I'm going to release you all with 1 minute to go. Please go watch the debates. Make sure whoever you want to vote for, you vote. And we'll see you all next week.